Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. Today's episode features an expert-led discussion on the current landscape of HPV in the United States. We'll hear from Dr. Sharon Humiston, Director of Research at Immunize.org and Associate Editor of IZ Express. She'll tell us how improving vaccine uptake can prevent certain types of cancer. For more information on Dr. Humiston, and for more information on this entire program, please visit the show notes for this episode. Now let's get started and hear from Dr. Humiston.
We're going to start by talking about the true burden of HPV infections. You probably know that HPV is the most common sexually transmitted infection in the United States. Nearly all people who are sexually active is a funny term because I think that sometimes when we say sexually active, people think that what we mean is promiscuous. Sexually active means having had sex. So nearly anyone who has had sex will contract HPV at some point in their life. And that is such an important fact because, like we were talking about in Canada, the Catholic schools didn't want to give HPV vaccine because it's associated in people's mind with promiscuity. But if your kid is going to get married, chances, that one would hope that they would have sex. A friend of mine used to say that to the parent, do you want to have grandchildren someday? Because if you want to have grandchildren, the only way for that to happen is for your child to have sex someday. And so it's not just sex outside of marriage. There's nothing that happens that sterilizes you at the time of getting married. So everybody should get this vaccine. HPV infection is more prevalent in males than females. And I underline that because we've all sort of been inculcated with the thought that cervical cancer is just the only kind of cancer that's important, but that is not true, and that HPV infection is actually more common in males than females. Most infections do resolve on their own, but those that persist can change the cells in a way that make it so that there's cancer, which to some people is still a surprise. My sister has 2 master's degrees, but not in medicine. And when I was talking about, what are you doing today? And I explained that I'm talking about HPV and that it causes cancer. And she's like, there's a virus that causes cancer? I think that to lay people, that still comes as a surprise that cancers can be caused by a virus. There are more than 200 HPV types. And this is, again, when we first started talking about HPV, that some people would ask me, oh, my kid gets warts? Just warts on the skin. Will the warts from the skin end up causing cancers? If she has a wart on her finger and touches her vagina, will she? And those are 2 different kinds of HPVs. The mucosal invasive type are different. Most of the cervical cancer is caused by 16 and 18, about 70%, although those aren't the only types, which is why we have an HPV with 9 types in it now. And then the anogenital warts are caused by 6 and 11, which are also covered by the current vaccine in the United States. How many kids do you need to treat with HPV vaccine in order to prevent anogenital warts? The answer is 8. So if you can increase from where you are now just by 8 a week, you're preventing. And then you go all the way to cervical cancer, it's 300. If you can get 324 extra HPV vaccine doses in this year, you will have prevented a cervical cancer case. The HPV-9 vaccination could prevent up to 90% of cancers caused by HPV. Very exciting. One of the surprising things is that oropharyngeal cancers are the most common overall. There are 14,800 each year in the United States caused by any HPV type. So that is the most in any site. But it's kind of obvious because both men and women have an oropharynx, whereas only women have a cervix. Cervical cancer is the most common in females, but not the most common overall. HPV cancers, there are more in females than males. Even though males have more infections than females, more females get the cancer from it. So a little bit of hair splitting there, but the main point is This is a vaccine that everybody needs. It's not just a vaccine for women. And I think that when we first started giving it to males, there was some, like, my son doesn't need this, he doesn't have a cervix, but he does have an oropharynx. So, all right, HPV transmission, it only takes one encounter or one partner to transmit the infection. And again, one of the misunderstandings is, well, if somebody doesn't have symptoms, that they won't transmit it. It's not like herpes, where you're looking for some sign that the person has HPV. In most people, you're not going to see a sign. It's spread through direct contact with an infected area, and it can happen from asymptomatic contact. You don't have to have penetrative intercourse. That is not the only route. And that's important because a lot of people think, well, my kid will be a virgin when she marries a virgin, and so she doesn't need this vaccine. I would never say to a parent, well, that's not going to happen. I would never say that, obviously. So this was a study among 88 male virgins. The prevalence of HPV in genital exfoliated cells was 25%. The idea that somebody is a virgin doesn't necessarily mean that they haven't had exposure to HPV. And among those 88, 18% had the high-risk HPV types. So basically, even if you're a virgin, you can still have HPV and have been exposed to HPV. So males and females, everybody needs this. Another thing that we have to get out of the way is that this is a new vaccine. It is not a new vaccine. It was first recommended in the United States in 2006. So we're coming up on 20-year anniversary, not far off now. And then the recommendation for males was in 2011. We dropped down from a 3-dose to a 2-dose schedule for people who were less than 15, who started the series before the 15th birthday in 2016. And then the later vaccination is started in 2019. My point with this slide is we're not talking about something that's new. This vaccine has been around for a long time, and that's in the United States. Another thing that I want to bring up is there's a little bit of confusion about when to start. And I think the American Cancer Society has really emphasized starting as early as age 9. If you start at age 9 or 10, you have more opportunities to complete the series by the time they turn 13. The CDC recommendation says it's recommended for ages 11 or 12 and can start at age 9, whereas AAP is just slightly different. It's recommended for all adolescents starting between 9 and 12 years of age at an age that the provider deems optimal for the acceptance and completion of the vaccination series. So they're just slightly different, but the take home for me is that in your practice, if starting at 9 works, that's approved by the FDA, fine with the CDC, and fine with the AAP. So that is part of the recommended. And I think that a lot of people are interested in starting at 9 or 10, partly because it makes it so, adolescents sometimes, are more vocal about pain and anxiety than younger kids. Or maybe we pay attention more because they're verbal about it. But getting 3 vaccines at once, so if you're getting meninge, HPV, and Tdap at the same time, you only have 2 arms. And then you add in flu and COVID, you get a lot of resistance then. So by spreading it out, I think that's one advantage of starting at 9. But then the other thing is that I think a lot of pediatricians, I've done a lot of work with quality improvement in various states. And a lot of pediatricians have said that by starting at 9 or 10, that what happens is that they kind of got rid of the whole sexuality issue. They could just focus on this is a cancer prevention and not focus so much on transmission. Okay, so I always think about this. When you gave somebody a polio vaccine, did you talk about fecal oral spread? Did you say, there's a thin film of doo-doo everywhere? No, you did not. And it's the same with HPV. You don't have to talk about the route of transmission. This is a vaccine that prevents cancer. Again, in our quality improvement work, we have found that parents they get it when you talk about wanting to prevent cancer. When you start talking about preventing a sexually transmitted infection, that doesn't apply to my kid. And obviously, this is another thing that this isn't like a vaccine that you're going to give to treat an infection that's already there. Once the infection has been established, this vaccine isn't effective. There's vanishingly few kids that are sexually active at 9 or 10. And so by giving it early, we make sure that it's before they've been exposed, because you could be exposed with the first encounter. First encounter, I always think the sexual debut. And that always makes me think of the sexual debut sounds so elegant, like you're going to be wearing a tiara and gloves. No. So now I move to the part where I want to show you the evidence that this vaccine is remarkably effective. We talked about all the different ways that it's been shown to be effective. And I talked about how you only need to treat 8 people in order to prevent genital warts. Well, this is HPV infections, just infections with the types that were in the original vaccine, 16 and 18. And it goes by year. So 2003, 2006, we weren't using the vaccine. That's the pre-vaccine era. So you see that in terms of infection, the younger group, there's been an 88% decrease in HPV infection from 2003, 2006 to 2015, 18. And in that 20 to 24 year bracket, there's been an 81% decrease in infection. Very exciting. Unfortunately, this is a country where not everybody's been vaccinated. And so in other places where they have more effective ways of getting adolescents vaccinated, like in schools, for example, that we might see even a better response. But this is an incredibly good response. Now let's move from infection to cervical precancers. When we first started talking about HPV vaccine, I didn't know why we cared about cervical precancers. It's a precancer, so what? But the so what of precancers is partly because once you have a precancer, then you have to be followed up, and it's nerve-wracking to be examined every 6 months to find out if your precancer has turned into a cancer. So that's one thing. And I always think about one of the things about vaccination is this is so much easier than so much of what we do as pediatricians, because it's not like changing their diet or changing their screen time. I mean, this is a one and done, 1 or 2 and done. You don't have to make, with improving eating, you have 100 decisions. That family is making 100 decisions a day about eating right. Whereas with HPV, preventing a cancer, that can be done with 2 decisions. Yes, and it's done. So precancers, the reason why this is so important is also because if you have a cervical precancer, one of the treatments currently has been that they scoop out the os of the cervix to take those cells out so that they don't go on to be cancerous. Unfortunately, that is associated with having what is known in medicine as an incompetent cervix. I have to say, incompetent cervix, isn't that the most sexist thing? Even my cervix is incompetent. So by having an incompetent cervix means that I might have a premature infant, or that I may not be able to take a pregnancy all the way to term. So preterm delivery and miscarriage. Unfortunately, one of my friends had this where she couldn't carry a pregnancy to term because she had had a cone biopsy. The number of precancers by age group over time it has decreased. So now we're up to cervical cancers. And this is a study with 1.6 million women from Sweden from 2006 to 2017. You see that the cumulative incidence of cervical cancer in unvaccinated, up, vaccinated at age 17 through 30, up, but not as much as unvaccinated, and vaccinated before age 17. So this says 2 things to me. One is, yahoo, if we can get people vaccinated before they're 17, I have a real chance at preventing cervical cancer. But the other thing it says to me is that even vaccinating people between 17 and 30, it's better than no vaccination at all. That's a real improvement too. And so ideally, we get it done early. But if we don't get it done early, just get it done. Then one more piece of evidence that I want to show you that this is very new. This is from an article in 2024, and it shows the males. I won't go into a lot of detail here, but males 9 to 39 years of age attending any medical encounter from 2010 to 2023. For males, any odds ratio less than 1 means that there was an improvement. And here, the vaccinated males had an odds ratio of head and neck cancers of 0.44, so far below 1. That means it's statistically significant. So it looks to me like clinically significant 0.44 and statistically significant both. So this vaccine is also preventing cancers in males. So overall, the benefits include genital HPV, cervical precancers, all the, cervical cancers and oral pharyngeal cancers. Real improvement.
Thank you to Dr. Humiston, and many thanks to you, our listeners, for joining in. As a reminder, to view the full educational program, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcast, Google Podcast, or Spotify. Thank you, and we'll see you on the next podcast soon.